Thanks. And I just want to say thank you to the panelists as well. I learned so much from all of you, and I think you are inspirational. I'm excited to be able to hopefully report back to you about how Ontario does. We are excited about it, but thank you for sharing your insights. I think they're just so very valuable. So I appreciate it. So I'll share my screen and I'll kind of walk you guys through this, and I'm happy to answer questions at the end. I'll try to make this brief since it's already 8:30 and you've been sitting for quite some time. I appreciate your patience with me. So hopefully you see my screen here. Yeah, okay. Wonderful. So MAPflow is minor ailment prescribing workflow. It's a software for Ontario, built by pharmacists for pharmacists. This is the dashboard. So when a pharmacist logs on, so you see my name up here, my pharmacy is up here. And if I work for more than one pharmacy, it would all be listed there. There'd be a drop down there and I would click on that pharmacy. Here you see how many minor ailments were assessed, which ones they were, and that can help you identify maybe gaps in knowledge for your staff, or maybe you're just not promoting certain ailments as much as others. You'll see how many patients in the system, all of these really important pieces of information that may help you as a pharmacist better understand your patient population, as a manager, understand what's happening in your store with minor ailment assessments. On this side, you'll see that there's completed services. And so in Ontario, for minor ailment services, there is that initial consultation where you meet with the patient, you assess. If you do prescribe, there is a follow-up that's required. And so the follow-up takes place afterwards. So here you'll see how many assessments have been conducted without follow-ups, that's 27%, and how many assessments have been conducted with follow-up. So, completed the circle and you've kind of done both things for the patient. And so those assessments without follow-up will also show up here on the dashboard, and you can kind of sort by ailment. You can sort by when it's due by pharmacist who's assigned to it, any of that. But that'll make sense after we kind of go through one of the assessments. So very simple and intuitive, I think. You could just start typing in a patient's name or a letter, and you see a number of patients pop up from my pharmacy. Let's go with Belinda. So Belinda is in my pharmacy, and now I'm going to start a new assessment for her. We're going to select an ailment. So there's a drop-down list of all the different ailments that are here. Sorry, did somebody want to say something? Oh, maybe not. It's feedback on my computer. So she's 24. Let's go with primary dysmenorrhea, menstrual cramps. So first things first, per OCP's guidance, regulatory restrictions, we need to make sure that the pharmacist is really getting informed consent from the patient, that they have the knowledge, the skills, the judgment to be able to assess this ailment that they just selected. So if they do all that, they can click yes to all and create the assessment. So on the far left-hand side, you'll see the patient's name and the ailment that we are assessing, and you'll see 5 steps here. And these 5 steps correspond to the pharmacist patient care process. So you have collect subjective and objective information, assess that data and identify drug therapy problems, create an individualized care plan. Step 4 is implement that care plan. So that could be, referral, that could be actual prescribing of an agent. And then step 5 is the follow-up. You'll see that the CPS link is right there. So we are integrated with the CPS. So we have that partnership with CPHA, and you can open that CPS and it'll open in a new tab and it'll go right to that ailment if you require more information on the condition. First things first, every ailment is structured the same way. It's what are the patient's presenting signs and symptoms. And what we want to do here is just ensure that the patient who's presenting with a self-diagnosis of primary dysmenorrhea truly has signs and symptoms consistent with that. If they don't have any of these things and you click none of the above, even if they're in moderate or severe pain and you try to proceed, it won't let you. So we have all these safeguards built in around that. So it'll say referrals required. If you confirm it, it'll print a referral form that's auto-populated with a rationale for that referral. And it'll say rationale, patient's clinical presentation is not consistent with primary dysmenorrhea. And you could use that to notify the primary care provider or conduct another service. But if that was a mistake, you can click cancel and go back and read about all the different signs and symptoms. If somebody, didn't know what suprapubic meant, you can hover over this question mark, which is our tooltip, and it defines it for you. So it gives you a lot of information. It's kind of a just-in-time learning. And I think that's going to be valuable for maybe some of our seasoned pharmacists who didn't maybe receive as much assessment in school, or even some of our newer grads who are just not as experienced or confident assessing. But you can go ahead and select whichever signs and symptoms are there, and that will auto-populate in the documentation form. The degree or severity of pain is there. And so the tooltip will tell you how to ask your pharmacist about that. And I forget which one of our panelists said, once you're familiar with this and you're going through this, it's not an assessment anymore, it's a dialogue. And it just feels very organic. And that's what we hope that this could do, to give you what you need to make sure that you are providing a comprehensive assessment, but at the same time, making more of a dialogue than a formal assessment with you writing things down. So then it goes through things about, what would preclude NSAID use, and that would be grounds for referral, because for primary dysmenorrhea in Ontario, we only can prescribe NSAIDs for them. So, in Alberta and Nova Scotia and even Saskatchewan, you can initiate hormonal contraception, which is first-line therapy for primary dysmenorrhea. If you were to do that in Ontario, you'd probably lose your license. We don't have the scope for that. So anything that would preclude NSAID use would be listed here. Any allergy history that is pertinent to primary dysmenorrhea is listed here, and then you can continue. Social history questions are always asked, and they're different based on ailment. So this is a dynamic form. Every time you answer something else will happen. And later down the road, it will tailor your therapy accordingly. So you might be thinking, well, what does alcohol consumption have to do with primary dysmenorrhea? And in fact, if somebody does report heavy or moderate alcohol consumption, then they shouldn't be given acetaminophen as a therapeutic agent. And so what would happen is if I click this, it'll gray out acetaminophen in my therapeutic options. And that's because of the risk of additive liver toxicity. So again, we've crafted this in a way where every single question you're asking is meaningful. It will do something to tailor therapy. Smoking status is directly tied to dysmenorrhea. And so, heavy, moderate, light, if you don't know what that means, you can hover over here and it'll say a heavy smoker is one who consumes a pack or more of cigarettes a day. If I were to click that in my plan, it'll then trigger smoking cessation, and it will give me the rationale for why that's important for somebody who does have primary dysmenorrhea. And it's all about, the nicotine-induced vasoconstriction, which can worsen cramps and all of that. Physical activity, again, something else that's important here. So if I type in no physical activity, it should prompt some exercise when we get to the plan. So next, we ask about whether or not the patient's sexually active, yes or no. If we click no, nothing will happen. If you say yes, we get more questions that pop up. And so has that person had a pelvic exam in the last 3 years, yes or no? Again, we have a lot of information here. So we've linked it to Ontario's cervical screening program and their guidance on that as to when you should have a pelvic exam. And so info is there if the pharmacist needs it. If they already know it, they don't need to see it, and they can kind of just proceed as they wish. So I'm going to say this patient has not had a pelvic exam and has not been tested for STIs in the last year. And that should prompt it down the road for me to notify the primary care provider. And then what are the patient's contraceptive needs? So if they are currently on hormonal contraception, it'll ask it. If they require or desire hormonal contraception, it'll then give me the option to refer to a primary care provider or someone who could prescribe via a pharmaceutical opinion. Or it'll allow me to prescribe right now an NSAID, and then after I finish prescribing, then I could do a pharmaceutical opinion or contact a prescriber for hormonal contraception. So that information's all there in the tooltip for the pharmacist. If the patient's not interested in hormonal contraception, then we can proceed and we can prescribe an NSAID. Red flag signs and symptoms for every ailment. And I think a panelist was saying, be familiar with them so that when they're present, you're going to have to refer. And if they are present, if there's unilateral pain, that's not typical of primary dysmenorrhea, then I'll show you what happens. It'll prompt referral, and it will put that in the rationale for referral for you. But if none of the above are there, you can just proceed. Next is a really important step of ruling out other conditions. So ruling out secondary dysmenorrhea. And secondary dysmenorrhea would present with any of the following signs and symptoms. More information is always there for you. And again, kind of a definition if there's a term in there that not everyone would know. But if you just click no, none of the above, then you can proceed. And then you go to this page of classification of condition. I don't know if you saw that. So I went directly from here to here, and it auto-classified the condition for me. And that's a really important step. So based on all of my answers thus far, I have now ruled out any type of secondary dysmenorrhea or pelvic pathology that could be causing these symptoms. I've also indicated the pain is moderate in severity. So the classification of the condition is primary dysmenorrhea, painful menstruation in the absence of pelvic pathology that is moderate in severity and restricts daily activities. That's different than one that's mild or severe. And if you want to know just why is this different or how is this going to impact my plan, you could just hover over the tooltips and it'll give you the differences, what moderate would do versus what mild would do in terms of your plan as a pharmacist, versus severe, versus if you're unable to confirm that patient's self-diagnosis. So next, these are built in more for research purposes, but we want to know if the person's ever received a medical diagnosis, yes or no, and if they visited a primary care provider or urgent care emergency department. And this speaks to Angeline's point where we were saying, hopefully we can kind of gather data about whether somebody is double dipping or whether, they are truly falling within these treatment gaps and coming to pharmacists for this type of care. And hopefully we can capture some of that data with this tool. What therapies have been tried in the past is asked about. So that would go into your rationale for prescribing, which is required by law in Ontario. So if I were to say, this combination product, this is Midol. I've tried Midol, extra strength. Was it effective? No. Was it well tolerated? Yes. Again, that will go into my plan and it will go into my rationale, for prescribing. So I went to next, it's my non-pharm strategies. 2 are auto-selected for me based on my responses to earlier questions. So smoking cessation and the rationale for that is there. Physical activity, because I indicated that I did not have any physical activity. That's there as well. And again, the rationale, because it will provide a clinically significant reduction in primary dysmenorrhea pain intensity. If I don't know about topical heat, should I recommend it? Should I not? Again, you can go here and hover over and read about it. It's easily accessible and affordable, so it should be recommended for all patients with PT pain. So I'm going to select that. If there's something else I want to add that I haven't incorporated in the algorithm, you can just type it in here as well, and then you can proceed. Now, this page here shows you the therapies for moderate primary dysmenorrhea. And it may look really simple. It actually took quite a bit of time to come up with these, and I'll show you why. So if you click on, I told you guys that I have this bookmarked, but if you go to Schedule 4 of the regulations here in Ontario, you will see for dysmenorrhea, you can prescribe 280804. That is the AHFS classification that you can prescribe within, but the agents are not listed there. Again, so here, if you go to any of these agents and you click on them, the AHFS class is there. So you'll see 280804, compare that to the regs. Yep, I am within scope. I can prescribe that agent. The other thing we've done is we've auto-populated all of the common and Health Canada approved dosing for all of these different ingredients for you. So, they're all listed there for all the agents. Brand names of products are there as well. If you go to like an ibuprofen and there's a lot there, you could do 600, 800, you could do a loading dose. You can just change that to whatever you want. So it still allows for autonomy by the pharmacist, but you have a good starting point. You have what is Health Canada approved for primary dysmenorrhea. So I'm going to go with a loading dose because I know that those work a little bit better for primary dysmenorrhea. TID, 3 to 5 days. Quantity, I'll put in, 30. Refills, I'll put in 1. That information will then go and auto-populate into a prescription that will print. Next, we're in the implement stage. So we have counseling points on the minor ailment itself. Because I indicated that, pelvic exam has not been done, that's been checked off. STI testing is now recommended. That's checked off, and that'll go straight in my documentation report and flag it for the primary care provider. These are other things. If I want to counsel on them, you can select them all, and then the patient will get a report at the end that will have all of these things listed there as well. You then have counseling points on the actual care plan, not the ailment. So this one's a little bit easier since it's only NSAIDs. So anything about NSAIDs, how to use them would be there, how you shouldn't be taking them for the entire month long. It's really for the first 2 to 3 days. All that essential info is here, and you could select all, and it will go into your report. Follow-up consultation, as I mentioned, is a required component of a minor ailment service in Ontario. So if you're not sure when to follow up with somebody that you just initiated therapy for, you can hover over our tooltip, and we have best practices for all the ailments. But it will say, 1 to 3 months after initiation of therapy. So if I click on my calendar, today is the 7th of December. 1 month will be the 7th of January, which is wild. So I'm going to select that. How do you want to follow up? I will follow up via telephone, and I'm going to assign myself to follow up. And when I do follow up, I'm going to make sure I monitor the effectiveness of the care plan and the safety of the care plan. So the monitoring parameters for both of those things would auto-populate in my documentation. Any other counseling, I'm going to say counseled to discontinue Midol. Next, any red flag signs or symptoms or atypical signs and symptoms that would warrant medical attention that I would counsel on, I could select all. And again, that would go right into the patient's record there. Lastly, as a requirement in Ontario, just like with renewals, we do have to notify primary care providers if we do initiate therapy. So here, does the patient have one? Yes or no? If they don't have one, you would click no and just document your discussion with the patient that they don't have one. You would give them the documentation instead. But if they do, you could put in their name. I'll put Sherry Smith. The date you notified the primary care provider must be recorded as well. So that's today. How did you notify them? And by fax. And so once that's done, you can confirm, and you get this nice printout of your a summary of your assessment. So the patient's there, my info's there, my rationale for prescribing, which I forget which one of our panelists also mentioned, that's got to be robust. That's got to tell a story. And, in case somebody comes back and says, well, how did you come up with that? You need to be able to say, well, it's in my rationale for prescribing. What you initiated in the plan will show up here, both the non-pharm strategies as well as any prescription or non-prescription strategies, counseling provided, monitoring and follow-up plans there, when it's going to take place, consent notification, all of that. But if you click on generate prescription, you get a prescription that prints with exactly the information that you have, or the agent that you've selected, with that information that you put in the system, your name and your registration numbers there, your pharmacy, all of that's done for you. So you have that readily available. And so when Belinda is followed up with, and whoever in the team is going to be assigned to follow up with her, you could just go to this here and start the follow-up, launch it right away. And it's only a few questions. And here we just want to know, since that initial consult, did you end up going to see a primary care provider or an emergency department? What happened after that initial consult? Hopefully they didn't have to. And then did you adhere to the recommendations made? Yes or no? So, adhere to pharmacologic recommendations. What about non-pharm? We're capturing that info. Next, assessing the effectiveness of the care plan. So whatever you gave this patient, did it work? Was there complete relief of symptoms, partial, no relief? Did symptoms get worse? The interesting thing here is, initially we just had those simple 4 options and nothing more. But then I realized, we really need to be able to support pharmacists in what to do next for continuity of care purposes, for optimal health outcomes for the patient. So we now have information on what the next steps should be if you were to report partial versus complete relief of symptoms versus none versus pain worsened. So all of that's there. Sometimes it'll prompt a new minor ailment assessment. Sometimes it'll prompt a renewal. It depends on what you select. Adverse effects of therapy, common ones, rare ones, what would happen if you get one of those rare ones, or no adverse effects. And then finally, did any new atypical or red flag signs or symptoms present since the initial consult, yes or no? So once that's done, you've completed your assessment, the initial one and the follow-up appointment, and that patient is now recorded in your system under assessments performed, last week. And if somebody were to, look up that patient, they can find the results of that patient's assessment from the past, year or however long they had that assessment done. And so they can see kind of everything that last pharmacist did, what they gave, did it work, did it not? And then hopefully they can either clone that assessment or do something different if it didn't work. So I know I spoke for a long time and really quickly. It's 8:54, so I'll stop sharing and I'll take some questions. Jen, I don't know if you want to moderate that or if you want me to go to the chat. Happy to do either.
Sure. If you'd like me to moderate, I absolutely can. I know we've had a lot of questions around being linked to the pharmacy's dispensing software, clinical schedulers. Can you speak to the plans around things like integration?
Sure. So we have built this in a way where it can and will integrate with pharmacy management software. At this moment in time, it is a standalone product. It's web-based. And I think there's value in that as well. And so I was speaking to one of my students yesterday, and I said, you as a student going into your co-op can do this assessment in the consultation room on an iPad, on an iPhone, not tie up a computer terminal in the pharmacy. And so I think there's value in having it be so versatile and be able to really do it without tying up a terminal. So, however, we recognize that there is a need for integration, and we are certainly working towards that.
Absolutely. I know we have a lot of questions in here around AHFS and, that focus on ensuring that we're prescribing within scope. This isn't necessarily specific to MAPflow, but I think, one of the core foundations of when you looked to start building some of these algorithms and tools for use in Ontario, that this was really highlighted in that jurisdictional difference between what was currently out there. And, maybe just speaking to some of the ways in which people access it currently. I know you've talked a little bit about that, especially in the context of it being embedded within MAPflow. But maybe just a bit more context around AHFS, if there are any plans in the regulations to adapt the regulations to maybe remove that ring fence and, this piece around using that classification system within the regs.
Sure. Yeah, I would say that's kind of what prompted me to say, oh, wow, we need to do something different in Ontario because, I think Saskatchewan guidelines are incredible. They're so well done. And I've always advocated to have access for our students for Saskatchewan guidelines. We've always paid for access for all of our students and faculty. And I thought, now what are we going to do? Now that we have a different system in Ontario and AHFS is no longer available on Health Canada. So we worked really hard to ensure that that's dealt with MAPflow, just to ensure pharmacists, it's not a rate limiting step to implementation of the service in practice. If you have a tool that enables it and you can see AHFS classifications for agents, then it'll just make it that much easier. However, there are ways around it. The ODB formulary has AHFS classifications still on there, publicly available, but only for agents that are covered by ODB. So that's one. I always go to NIHB and I search there as well, but there isn't one comprehensive list out there. There is not any that I'm aware of. And so that's what I'll say about that. And I think in OCP's defense, nobody knew this was coming. Nobody knew that Health Canada was no longer going to have this ability to host AHFS. So it's difficult. And I know OCP is working hard to get workarounds. And there are some rumors that, Health Canada would bring back AHFS temporarily for a few months in the upcoming year. So that might happen. But again, things like MAPflow, having an AHFS subscription, if that's what you want to do, and using your professional judgment, that's all going to help. Again, the CPS is going to get updated with time, and all of those ailments are going to have some indication of which drugs are covered. So that's the best I could do to answer your question.
It's a tough one for sure, because that future with that system doesn't necessarily look extremely clear, and there's some limitations there. Absolutely. We do have a question here around privacy. So it appears that the system stores patient information. Where is it being stored? And maybe just if you could speak to some of the privacy impact assessment that was done around the tool.
Sure. Yeah, we've done all of that. We've done all the hard work. We have a privacy. We're PIPEDA compliant. We're PIPA compliant. Any information that's stored and used for research purposes will be de-identified patient data. And so we've kind of worked our way through all of that, and it's in the end user agreement. We've done our due diligence with all of that.
Excellent. Really a practical question. So how much is MAPflow, and how do you access it?
Right. So MAPflow is $300 per pharmacist. OPA members get it for $250 per year. It will be available starting January 1st. So for launch, you can purchase it right now, but it will be available starting January 1st, and it will expire the last day of 2023. What was your other question about that?
Just about how you access it. So right now it's available for sale on the OPA website. There will be additional avenues moving forward to purchase it, but right now both members and non-members can purchase it with OPA. I would do the special call out to all of you who purchase our owner's bundle for the other value-added services within that owner's bundle membership. Your MAPflow subscription, if you're looking for just one subscription for you personally, is included within that, and you do not need to purchase an additional subscription if you are an owner's bundle member.
Right. And I just saw another question pop up that I just want to address, Jen, if it's okay with you. So how is it comparable to algorithms and charts offered by other pharmacy softwares? I will just say that my entire career is, focused on self-care and minor ailment management, and non-prescription therapeutics are a passion of mine. So I built that in, which is, I think, a unique feature that is very important to me. So whenever you're assessing for an ailment and there is maybe a differential diagnosis that can be managed using non-prescription therapeutics, it flags that. So we have OTC consults that will print out for the pharmacist and for that pharmacy, and it'll say, a good example, Michelle just talked about this. So atopic dermatitis, and one of the differentials is scabies, right? And fungal infections. So if the presentation is more consistent with scabies or fungal infections, what will happen is it will refer, but it'll refer to the pharmacy for an OTC consult, and a form's going to print and say OTC consultation required. And it'll give a rationale there. It'll say patient's clinical presentation is more consistent with whatever ailment you can manage and practice. Please consider conducting an OTC consult. So it flags for additional services. It also flags for things like pharmaceutical opinions. Again, this is made for Ontario, so very much Ontario-centric, but we will roll out nationally, and then we will adapt to those provincial guidelines. But in Ontario, we're speaking that language, and we're kind of ensuring that you're not just ruling out conditions and leaving them if they are presenting with other ailments that you can still manage as a pharmacist. We are making sure that we are capturing those patients and ensuring that they're getting care. We're increasing access to not only the minor ailments, the 13 we have in Ontario, but really all minor ailments. And I think Michelle said it beautifully as well when she said, dry eye disease. So we don't have that. But when we assess conjunctivitis, I built it in where we talk about dry eye disease. And if there's drugs in there that are causing those symptoms, then you are going to deal with that, but via a different pathway. And it's just going to open up the door for, other services, other opportunities, establishing that rapport with the patient, and really just ensuring that at the end of the day, we're providing patient-centered care, and we're doing so in a very systematic fashion that could be tracked, where documentation is done in the moment. You don't have to think about it. And I would say, we have average times for assessment of minor ailments that we have in the platform, and it takes on average 6 to 7 minutes to complete an assessment from start to finish, 6 to 7. And
with documentation.
With documentation complete, and it's in the moment. So 6 to 7 minutes. So, I recognize that this is another service pharmacists have to find a way to make time for. But again, if you can cut down from 30 minutes, 15 to 30 to 6 to 7, increase that efficiency and give pharmacists confidence and confidence. You have tooltips there. You could just reference it. If you don't know the answer why you're asking a certain question, it's there for you. So hopefully that can serve to help pharmacists as well. Sorry, I went off on a tangent, but
no. All good. I think too, there have been some questions and, just to be fully transparent, with the company itself. So MAPflow is a for-profit company. There are 4 main shareholders and we are promoting it here as OPA as one of their shareholders. It is led by Nardine, with partners, with Dr. Andrew Edington and Mikhail Silvestre, who has extensive experience in the health programming, and coding, environment. And OPA is the 4th shareholder as a partner in MAPflow. So, as we talk to the product, we're speaking to its merits to you here today. There are other softwares out there, and we would encourage you to go and evaluate what is going to best meet your needs. And MAPflow is one of those tools and options for you. And we were very excited to partner with Nardine. And we just wanted to be clear that it is a separate entity. It's not affiliated or produced by the University of Waterloo.
Sure. And I'm going to add, it's not just me, for sure. From a pharmacist perspective, we have contracted many clinical and subject matter experts, both from the University of Waterloo and University of Toronto, to help us with, the content development. So it's certainly not just me, but thank you for that.
And I would say too, just we're seeing some questions around like the ownership of the subscription itself. So MAPflow is designed to be an individual level subscription for the pharmacist. So you can choose to subscribe to the service regardless of what practice setting you work within. And there's definitely the plans in the future roadmap after we address the Ontario specific needs to look at applicability in other jurisdictions, other practice settings like primary care that go beyond pharmacy, where this could be of utility. But our focus is on implementing the program to enable pharmacist assessment and prescribing services in Ontario, as they stand to have pharmacists ready from day one. But ultimately, if you are looking at your subscription, it is unique to you. It has your license number, your name on that prescription. You are affiliated to any of your workplaces so that you can share care of the pharmacy's patients. So there's a dashboard for the pharmacy itself, but your subscription is yours. If you would like, if say you have, I see a question here around, you have it in your owner's bundle, you could give that subscription to another pharmacist that would activate it, but you would not have one yourself. So if you were an owner looking to purchase multiple subscriptions for your pharmacy team, each individual provider would have their own subscription. And we just thought, once again, that was very important for pharmacists who may work in multiple settings, who may not have tools within their workplaces to be able to individually subscribe to a service that would support them throughout this process. I think a lot of other questions. I think perhaps what we might do is sort of take some of these questions from this demonstration and use it to guide some of our frequently asked questions and maybe, create that on our OPA MAPflow webpage. So I really appreciate everyone's time and staying, now 36 minutes past the scheduled end time of this webinar. We still have over 100 people on this webinar, which is just phenomenal, given I know how busy everyone is in their day-to-day practice. But we a lot of really complimentary comments here, and I can't put emojis in the text back to you, but I just wanted to thank everyone for their compliments on it. I know the team is extraordinarily proud of this product, and we're really excited to see it in the hands of Ontario pharmacy professionals taking care of their patients in January. So with that,
Really see your message. Maybe in 2023, we have no plans of tackling meds checks right now. And we're very focused right now on minor ailment prescribing. And my dream is to expand it out to just be minor ailment management in general, whether we have the scope to prescribe Schedule I or not. I think that there's a lot of work that can be done to optimize therapy and plans for all minor ailments using non-prescription therapeutics and prescription therapies. So thank you for that.
Yeah. So on behalf of everyone at OPA and at MAPflow, thank you for your time and attention tonight. As I said before, I can't say it enough. We look forward to hopefully imminently sharing information with you about the funding model and programmatic elements, all of those details that I know everyone's really eager to know about in the coming imminent period. I can't provide specificity because you never know with government in terms of when we actually get the documents to turn into that guidance and that communication. But please know that it is coming shortly. and we look forward to communicating that. And please, if you have any additional outreach or inquiry around your OPA membership, we are in drive for 2023. The MAPflow product itself, or anything related to our professional development courses, or the support you might need in order to feel comfortable moving forward with this scope, please contact us at info@opatoday.com, and our customer experience team will get back to you as quickly as possible. So with that, I will end the webinar. Thank you, everyone. And we look forward to this new scope on January 1st. It truly will be a happy new year. Thank you and have a great night.
Thank you all.